Good afternoon, and thank you for the kind introduction. My name is Chinkin, and I'm from Bacolod. I'll be talking about this topic. The following are the disclaimers for Johnson& and Johnson, and these are my disclosures. I declare no conflicts of interest for this presentation. I'd like to reach three things when we end. I wish to discuss the pathophysiology of pain. I'd like to show you my cases referred by colleagues, as well as introduce literature supporting pain management, especially with cases I encounter in practice. So this is the government census in Bacolod, and pre-pandemic, you can really see that there's an upward trend with major and minor procedures. The pandemic has decimated our outpatient services and cold cases. But despite that, you can notice that for major procedures, the numbers keep going up simply because diabetic foot infections don't sleep, as well as floating knees or femoral shaft fractures from motor vehicular accidents. Regardless of diabetic foot or a trauma limb on the lower extremity, these patients need proper pain control. And it is my hope that after this lecture, you may consider tramadol paracetamol in your practice. So pre-pandemic, you can notice that a little over 30% of the entire hospital census was referred to the foot and ankle service. And that jumped to almost 40%, 37%, because of the ischemic limbs that were evident in the present time. Now, it's very important to discuss the pain pathways. The anterolateral pain pathway is pretty much straightforward, but it's really an applicable basic science that we need to actually consider teaching our colleagues and our students. So when you activate the peripheral nociceptors from a trauma or pinprick or whatnot, it gets transduced and eventually transmitted to the dorsal root ganglion, where it will decussate and ascend into the cerebrum. In the cerebral cortex, we might be able to perceive or localize where it really is, and we get to modulate that through feedback mechanisms. So when you look at transduction, transmission, modulation, and perception, there are many drug molecules that can affect those pathways. And the more pathways that we inhibit or we include in pain control, the more successful pain relief will be for the patient. And this was a concept started in 1986 by the WHO. And as you ascend through the ladder in terms of increasing pain, you can consider including a weak or a stronger opioid for the treatment of your patients. This table just summarizes the NSAID versus tramadol acetaminophen or tramadol paracetamol. And you can notice at the bottom rows that tramadol paracetamol is very good for patients with renal failure, as well as those with heart disease. Tramadol paracetamol is also excellent for severe pain. So the mechanism of action would be for tramadol, it is a mu opioid receptor agonist. It is also a substance that releases serotonin, and it's a reuptake inhibitor of norepinephrine. For paracetamol, it really inhibits prostaglandin synthesis by blocking COXes 1 and 2. Now, it's very common these days to be receiving virtual consultations, and it does not replace the fact that you should really talk to your patient and touch the patient. So here, the patient is describing where the pain is. He's describing how it happens, and he's going to demonstrate or stress his foot on how he actually um, receives the pain or how it happens to him. And in the end, I always tell my students, you really have to touch your patient. And if it's face to face, that's the only way to go. But if it's telemedicine and the patient has nowhere else to go, then you are still at the better end of the screen helping another human being. So this was 18 years ago. This was the collegiate fencing team, and they're looking at the obstacle course in PMA. Someone in the team thought it would be a good idea to do cross training on top of fencing, so they did an obstacle course in the Philippine Military Academy. They had to go through logs, crawl through terrain, detritus, and cross narrow paths. And then there was a particular obstacle where after they reached the summit, they had to jump 3 meters to the ground, and that wasn't very favorable. In the end, though, after they successfully rappelled through Tower 66, it was a positive team building experience. But it wasn't very positive the next day because you have 4 out of the 24 members of the fencing team seeing an orthopedic doctor for foot injuries. And that foot doctor from 18 years ago was Dr. JP Leung. Dr. Leung, if you're here, thank you very much for taking care of my ankle. And basically, it was my first time to wear an ankle stirrup device. It was also my first time to feel what a black and blue limb would be. And it's where I got to emphasize what RICE protocol really means. So now Dr. Leung is still part of our faculty and continues to teach young orthopedic surgeons. And he led the men's saber team into its consecutive gold medal. So as a patient having suffered an ankle sprain in the past, these cardinal signs of inflammation are very useful when I explain to my patients. And I give myself as a classic example of someone who sustained an ankle sprain or a sports injury and recovered. So basically you have to look for calor, rubor, dolor, tumor, functionalesa. And basically you also have to consider the opposite of those when you're talking about diabetic or ischemic limbs. Because warm feet could also be cold and clammy, it may be not be red, it may be cyanotic, almost leading to gangrene. If it's not painful, there may be numbness. Some numbness can allow patients to go crazy and mad simply because they can't feel their skin and they want to feel their skin. And for patients who may have swelling, too much compression may lead to ischemic signs or with disuse, certain atrophy. So this is a diagram by a grade school student on how rice protocol should be. So don't forget to eat your rice. It's rest, ice, compression, and elevation. It's very different for you to show the patient what rice is, and it's extremely different when you explain to them what it is. So when I tell them about resting, they really have to rest their foot, meaning if they're seated, they have to put their foot or their limb on a stool. If they're lying on the bed, it's better because they're having no activity. And the more they stand, the more they sit up, the more swollen the limb would be. The more swollen the limb would be, the more painful the limb would be. Ice, 15 minutes every 4 hours for 2 days round the clock. C's for compression. A good rule of thumb when you're applying the elastic bandage is to give 50% overlap. And if you can insert 2 fingers through the 50% overlap, that's a very good compression. If 3 fingers can go inside, it may be too loose. If only 1 finger can go inside, it might be too tight. And E, finally, is elevation. If you don't use the limb, if the limb is above your heart, the swelling also goes down. So this is a student referral, a referral from my third year resident of a patient with ankle left pain after sliding. And this patient could not be sliding, this patient could be doing any sports activity as well. And these are the x-rays sent. I express my statements carefully that I don't appreciate anything much because of the poor x-rays taken. And the resident complies by sending me the actual screen capture of the radiographs. And he himself will modify the diagnosis as seeing an avulsion fracture of the lateral malleolus. So in the end, it's very important to have very good pictures. If the patient can't tolerate weight-bearing films, you don't have to force them, but maybe on follow-up once they've recovered, it would be great or prudent to have those injury films. So as per foot and ankle service protocol in my hospital, we apply these patients with a coaptation splint. We apply a short leg circular cast, partial weight bearing at 2 weeks, possible removal at 4 to 6 weeks. And you can see the patient already tiptoeing and with radiographic signs of union at the lateral malleolus of a healed fracture. Now, if there's one important slide in my slideshow, it would probably be this, and it's really on rehabilitation. I really rely on a lot of conservative treatment. So if I can medicate my patients to relieve their pain, that's good to go for me. But 90% of my practice clearly is conservative treatment, and I don't get to operate much on these patients. The RICE protocol in the second bullet has been emphasized earlier. And let's go to Tirador. If you go to the market and buy an elastic band for 10 pesos, it can replace your TheraBand if the patient cannot afford a TheraBand. But basically, you just tie it to the leg of the table, contralateral to the side of the injury, and you tie it to the forefoot of the affected side, and then you can start your external rotation exercises. And these really strengthen the peroneus, the lateral compartment, and allow for good rehabilitation of the knee. And you start this at 3 weeks when the patient has less pain to deal with. You can actually allow them also to spell the alphabet. You let them spell it OA exaggeratedly, full A, full B until Z, 2 sets. And then the good morning towel, you let them crimp up their toes, their forefoot on the towel, make a figure 4 to put it on the contralateral knee, and you throw it back on the floor. And maybe 10 repetitions would be good. Because in the end, we really want to prevent reflex sympathetic dystrophy. And it can be quite disabling if we miss or if we allow acute pain to become chronic. So this is a patient on the left, no swelling. You told him to do RICE protocol. You told him to do ankle stretches. He didn't want to. And you can now see swelling of the forefoot. And this patient had to deal with pain for the next 6 months. And we had to include gabapentinoids and other drug regimens just to be successful for his treatment. And all of this is initiated on the first contact. When the patient is seen at the emergency room, you explain this at the emergency room. At the clinic, same. In the ward, same. Now, for patients who persist with ankle instability, they have this complaint of ankle pain when they're walking on uneven terrain, or their ankle gives way when they're doing physical exertion, there are some objective measures that we can do. But first, it's really doing a varus stress test. Aside from the varus stress test, you can also do an anterior drawer test, and they're pretty straightforward, and it depends on how you do it. And there are also ways to measure them. You can use a goniometer, and for this slide, it actually uses the Telos device, which reproducibly, predictably stresses the ankle in varus and in anterior translation. So if you're looking at the middle graph on TT, talar tilt, you're seeing abnormal talar tilt because the tibial plafond should be parallel to the talar dome. So we're just drawing the angulation of an abnormal person with ligamentous laxity. And then you can see the anterior drawer, it moves a centimeter anteriorly. This is also unique for this patient. There's subtalar instability, and then it opens up on those views. The MRI of this patient shows a normal ATFL, but there's a torn CFL, giving that instability for this patient. These are different patients. Now notice as we do the varus of the ankle in stress, we can see the opening of the talar tilt, and that's abnormal. And if you look at the bottom, the talar tilt is open, but the interosseous cervical ligament that binds the talus to the calcaneus is ruptured, and it shows subtalar instability. And that's a completely different entity to deal with. Now, it's very easy to diagnose ATFL tears clinically, but if you want another objective test, I do the ultrasound here in my clinic. I tap on the probe to see which is proximal and which is distal, and then I'll put it on the medial aspect of the patient's, on the lateral aspect of the patient's ankle, and we can clearly see the osseous structure of the lateral malleolus. You can see the hyperechoes of the ATFL, which is intact for this patient. You can also do the same for the deltoid ligament. In 2018, we presented our paper in Boston for the AOFAS, and our MRI findings were as follows. The reconstruction for chronic lateral ankle instability really reconstructs the ATFL as well as the CFL, and this is the construct popularized by Jung. And this is what it looks like intra-op. So you have an allograft, you can use suture tape, and then you can use bioabsorbable screws. And our findings were that pre-op, post-op, maybe 2 to 3 years apart, we found out that the synovitis immediate post-op resolved post-op for our patients with increased AOFA scores. This patient shows a wavy allograft reconstruction. You can also see hyperintensity of the CFL. For this diagram, you can see the the chronological arrangement of the bioabsorbable screws and how the ends or the tapered ends of the screw is actually getting blunted simply because the bioabsorbable screw is being resorbed by the bone. Jung's group also popularized the classification and identification of ATFL structures in lateral ankle instability patient. And you can have a normal thickness, you can have absence or complete tear, you can have attenuation, and you can also have a thickened ATFL. Dance is an important part of life, and this is a patient who uses her feet for a living, and you can just really see how she can manipulate her foot into hyperplantar flexion and cavus. And she complains of pain in that position. And you can see the os trigonum on the rightmost lateral x-ray. And that's what it looks like on CT scan, on axial, sagittal, as well as frontal. And here it is in MRI. In magnetic resonance, you can see hyperintensity, which is really dealt with by the chronicity and irritation of the os trigonum with the patient in plantar flexion. So we have a minimally invasive procedure. We use an arthroscope. Here, there's a fear elevator targeting or triangulating where the os trigonum is. We placed a pin there, and now it's fully resected. That's the initial synovitis that we had to debride. We get to visualize the FHL in the cleared talar dome, and this is the patient post-op. We do a lot of regional anesthesia for patients simply because we want to allow them to go home the same day when we do procedures. This is the setup, hardware required. And this is a patient in a supine position. The probe of the ultrasound is on the medial shin at the tibial plateau. And the needle, the video on the right, will show that it's entering anterior. And then it's entering through the sartorial fascia. There you can see a hyperechoic structure at 10 o'clock, and that's the inferior branch of the saphenous nerve. Slowly, we'll be introducing 2 cc of anesthetic into that area, and you can see the hydrodissection pushing the fluid around circumferentially of the nerve, and it's bathed properly with anesthetic. After that, you have to bathe the posterior nerve, the sciatic. So the probe is now from posterior going to anterior. It's in the short axis. And then the needle enters from lateral going to medial. So the needle is entering, it's piercing through Volocca's sheath. The infiltrate, the lidocaine or ropivacaine is going inside. It's doing hydrodissection. From one fascicle, it's now turning into a peanut, splitting it into the posterior tibial and as well as the peroneal nerve branches. And as you do it posteriorly, you'll have to retract it and redirect it anteriorly so that you have full circumferential bathing. There's a hypoechoic pulsating structure, that's the femoral artery in that ultrasound probe. So slowly, we're redirecting the needle anteriorly. It's a slow process, but for the next 10-15 minutes after you're done with the procedure, it may allow the patient anesthesia effects lasting for 6 to 18 hours. So there's really a misconception when you deal with post-op pain. A lot of people say that it will just vanish in a few days, and a lot of people will claim that if the surgery was successful, the pain will soon be forgotten. These are completely false statements because surgeons, we may cause iatrogenic injury to the cutaneous nerves. We are making our own surgical incisions. And if you're not very careful, the cutaneous neuralgia might increase the patient's morbidity. It may affect their ambulation. It affects their quality of life because they have to deal with pain as well as impaired function. There's also a column by Applebaum and Gann. They mentioned that pain in the US is underrated, and they compared the decades of 93 and 03. If you look at the red and gray columns, from any pain on the left to extreme pain on the right, the later decade of 2003 had higher reported outcomes of pain. And you don't want to increase the morbidity in your patients. You don't want to give them impairment in their quality of life. And you don't want acute pain to turn into chronic pain. So this is an orthopedic surgeon with an ingrown toenail. A lot of my patients with ingrown toenails are in the health industry, in the allied health services. So basically here in my facility, I get to do the procedure under digital block. You get to resect using a partial nail avulsion, the contents of the nail fold. And this is at post-op, few months, and the patient, the orthopedic surgeon is happy, immediately gets to do surgery and rounds the next day. Just to simplify how it's really done, after spraying an antiseptic on the limb, we place non-permeable drapes, digital block, ring tourniquet, English anvil, just completion of the eponychial incision. We are gently removing the horn of the nail fold. We've resected it medially, tibial side, fibular side. Now we're applying a cautery device, silver nitrate, because you want to cauterize that peroxide to deactivate the silver nitrate, and then your favorite antiseptic brands. You put your dressing and your halox band and let the patient bathe on the wound on the second post-op day. It's very important to educate your patients. Number one for ingrown toenails is simply to cut your nails properly. They have to be done square. And it's my habit to usually show my fingernails to my patients just to show them how I would actually do my toenails as well. And it's really important to wear shoes. Your shoes should have a wide shoe box. It can never be too narrow because narrow shoe boxes tend to squeeze the halluces and allow you to get an ingrown possibly from the repetitive injury. This is an interesting study by Gerben Schagen. They outlined a lot of surgeries, 179 procedures, and they wanted to show which ones were the most painful ones. And orthopedics and traumatology ranked number 2. But in terms of the variety of procedures done, it was orthopedics that had the highest incidence of surgery types that were painful to patients. So if you look at the green bars, that's an orthopedic procedure. It's a foot ORIF, there's a spine procedure, there's a hand fusion. And they mentioned that severe pain after surgery, it will remain a really major problem, and it occurs in almost up to half of patients. And you don't want that because that patient might be you, your wife, or your child. So 80% of patients who have undergone surgery may have post-op pain. Most post-op pain is reported once the patient is sent home. So it's very important to give take-home medications for rescue. And less than half of post-op patients receive adequate pain relief. So the expected outcome is to have a pain-free post-op period. Why? Because you get to mobilize your patients very well. With motion, there is less incidence of arthrofibrosis, there's less atrophy, so it enhances the patient's recovery, maintains muscle power with minimal complications. You can look at it as a clinician, you can look at it as a patient, or even administrative, but pain is an important indicator of how well you take care of patients. As a doctor, it may give you sleepless nights if patients complain about the pain that they're feeling. For patients, it's needless suffering. It really affects how beneficial they are as members of society. Administrative, you don't want a lawsuit against one of your doctors or your hospital simply because of negligence. So you really have to address pain. This is a patient who I saw in my early private practice. He suffered a grade 2 ankle sprain because he was competing in motocross, and he sees me 3 years later because of this kind of injury. And you can see that there's a transendesmotic fracture, there's an increased measurement on the medial clear space, there's a long comminuted oblique fracture of the lateral malleolus. On CT HL, you can see the sagittal component or the frontal component of the fibular fracture, and you can see the clear space. On sagittal cuts, you can appreciate the Volkmann's fragment. Again, the lateral view also shows the oblique fracture, the fracture already seen on x-rays. This is the 3D construction showing the posterior instability because of the Volkmann's injury. The Volkmann's fracture can indicate in 40% of the time injury to the posterior column, and that's at 40% based on census or statistics on literature. So intra-op findings, we were able to reduce the clear space, we were able to reduce the syndesmosis. We placed a locking plate with a syndesmotic screw. This is what it looks like post-op. We were able to remove the syndesmotic screw at 3 months, and this is the patient at 2 years follow-up. The patient's very happy. Sometimes though, you don't or you can't get away with a deltoid injury and you have to fix it. So for this patient, the deltoid ligament was clearly unstable. You can see a higher syndesmotic injury, a higher fibular fracture, increased medial clear space injury, a small fleck on the Volkmann's fragment. The magnetic resonance frontal cut shows the invagination of the deltoid ligament marked by the red asterisk. This is what it looks like post-op, 1 year post-op after implant removal, and I'll just show you how we did it. So this is a medial approach to the ankle. MM is for medial malleolus, the bony prominence. D is for the deltoid ligament remnant. We applied a suture anchor on the osseous structure of the medial malleolus. We imbricated the remnant of the deltoid ligament and tightened it, layer closure, and this patient is very happy. So I'm about halfway through, more than halfway through my set of slides. I just want to tell you what an ideal pain drug is. A pain drug that's ideal really activates multiple pain pathways. So again, that's transmission, transduction, modulation, and perception. And in combination, they may reduce adverse effects as seen as compared to taking the drug one or in isolation. So Dillon et al. Mentioned that tramadol paracetamol is very effective in providing pain relief for musculoskeletal pain, acute, subacute, or chronic. It's very good with ankle sprains, low back pain, and it's better than paracetamol or tramadol in isolation. And it's similar to a combination of hydrocodone, paracetamol, codeine, and ibuprofen. This is another study by Hewitt. They did a randomized controlled trial comparing tramadol acetaminophen, hydrocodone acetaminophen, and placebo, all on patients with an ankle sprain. And they found out that 1 or 2 tablets of tramadol paracetamol, tramadol acetaminophen, or a capsule of hydrocodone acetaminophen were well tolerated and comparable for pain relief in these patients. So this is a patient who complains of global ankle pain. The X-ray otherwise just shows an lateral injury. But in the end, again, you have to touch the patient, you have to talk to the patient, and there really is medial pain. There's also posterior osseous tenderness. So for my students, I always emphasize the need for a CT scan for these injuries, no matter how simple they look at. So the red asterisk would point to the medial malleolus. The green arrowheads would point to the Volkmann's fragment as seen on the CT, juxtaposed with the X-ray. This is what it looks like intra-op, post-op, 1 year post-op. Prior to implant removal, we did an MR arthrography of the ankle just to see if there are osseous changes brought about by the post-traumatic arthritis. You can see a medial talar dome cystic lesion which was otherwise asymptomatic for this patient. Implant removal, 5 years follow-up. Patient is extremely satisfied with the procedure. This is by Shug from 2005. He basically said that when you mix tramadol and paracetamol, there's genuine synergy because paracetamol has rapid onset of efficacy. It works in as early as 15 minutes. And by the time that wears off, you have tramadol's prolonged analgesic effect. And the diagram on the bottom right just shows that the half-life of acetaminophen is 2 hours. That of tramadol is 6 hours. But when you combine them, it extends the half-life to 7 to 9 hours. So it's very good pain control for these patients. This is from Sawadiluk, outpatient hand surgery in Thailand. Blue, tramadol alone group. Red, Dosset group. And they were comparing the VAS scores post-op. And Dosset group would have decreased VAS scores as compared to tramadol alone. This is by Mochizuki et al. From Japan. They compared total knee replacement patients treated with tramadol acetaminophen as well as NSAID. In the tramadol paracetamol group, the patients were able to ambulate a day earlier compared to the NSAID group, and that might have cost implications for patients. Now, this is my final constellation. It's a diabetic foot because it's an entity I see all the time, every day here in my practice. After a pedicure, the patient complained of a non-healing wound on the hallux and eventually turned into dry gangrene. There's some lytic changes on P1 and P2 on the hallux, and then the ultrasound Doppler shows monophasic tibial artery, posterior tibial artery circulation. This is the residence plan of doing the resection for the below knee amputation. This is the residence below knee amputation stump, few months post-op. And you have to consider that even if you advocate prosthetic wear for these patients, not everyone can afford. So this patient had it fabricated out of PVC, and they heat treated it and they molded it based on the patient's stump. And this is how they fit it. This is how the patient ambulates. It's a bit of crude manner of doing 4-point gait, but the patient is referred to physiatry for retraining for proper gait so that eventually he may be independent from crutches, and then he may be able to transition to properly made orthosis. So these are some of the orthoses that I've seen or immobilization devices that I've seen in my residency, all handcrafted or commercial. And for patients who really can't afford, we make it in-house, the peg leg. And this is open source freeware. We slice the app and then we print it for almost 22 to 24 hours. This is the finished product. And with the patient's knee inflection, they're able to walk. But this is completely temporary. This is one of my more recent follow-ups for knee prosthesis fitting. This is the vacuum. That's the sound that you hear when you remove the mold. And then these are the measurements done in-house. After a week, the prosthesis is complete. You have to make sure that the patient can do full knee flexion and extension as compared to the contralateral. And this is the first day the patient is able to stand with a prosthetic limb. And this is a patient practicing at home. The patient wasn't able to follow up with me for 2 years, and she follows up now. I'm assessing how well they can independently do the prosthesis fitting themselves. They're able to do so, although she's very dependent on her husband. And this is how she walks at 2 years post-op. Not very assuring. In the end, no medication can help this patient, but the amount of confidence physiatry consultation, multidisciplinary conference can bring for this patient is priceless. And in the end, what's more priceless is education. And you really have to tell these patients that because they're diabetic, they may be prone to deformity, peripheral neuropathy, infection. And for peripheral neuropathy, you really have to address their pain. So for take-home points, when you're talking about tramadol paracetamol, it has more pathways targeted, resulting in better pain control. There's synergy between the two molecules, there's less opioid use, and there's faster recovery time. It's such a pleasure to be joining you in the lunch symposium. My name is Chinkin. I'm from Bacolod. Thank you for having me.